Right. This is going to be a brief 10-minute overview of the metabolic liver diseases and sort of a preamble to the whole meeting for the next day or two. I'm not going to be talking to you only about the definitions because we know generally what a metabolic liver disease is. Initially, we used to have different terminologies. We used to have diseases which were genetic diseases, dysmorphic syndromes, storage syndromes, metabolic liver disease. I think now as time has gone on, the gaps between each of them or the separating points between each of them have become less and less clear. And there is a sort of an amalgamation of all these terminologies. So when we talk really of a metabolic liver disease, we are talking about a disease which comes or results from an outcome because of the derangement of some metabolic pathway which occurs mostly in the liver but can occasionally have outside also. The storage, so-called disease like the storage disease is a part and parcel of the metabolic liver disease. There has to be some amount of metabolic derangement for us to talk or label a disease as metabolic disease. The liver, as you know, can be affected by various pathological processes, but the liver expresses itself only by a few limited outcomes, like an acute liver failure, a chronic liver disease, a coagulopathy. So very, very limited clinical presentations, but multiple disorders or pathological processes that can damage the liver. In the simplest form, if you would talk about any metabolic problem, assuming that there is a substrate A which goes to form a substrate B and an end product C, and if at any time you have a block or an obstruction in the process by which B cannot be converted to C, you could have a metabolic problem. And what could the metabolic problem be a result of? It could be a result of deficiency of C because C is not formed or is very less. A glycogen storage disease type 1 could be an example of that, where there is deficiency of glucose. You don't get glucose because of the block of the enzyme. You could get a problem because of increased amount of the substrate, that is B. This substrate can be toxic because normally it should not be of that particular level and can end up in damaging the tissues. Or you could have alternative pathways like D and E which are formed, which normally are not formed, but because there is a block, you get these pathways. And an example of this is galactosemia or tyrosinemias. So all of these processes lead to a disease which we call as a metabolic liver disease. Generally, most metabolic liver diseases, the baby is born normally. There are exceptions to the rule, especially related to some things like neonatal hemochromatosis or some energy deficient problems. But generally the baby is normal at birth because the mother takes care of the baby when the baby is in the mother's womb. The so-called toxic elements are cleared off by the baby because of the placenta. If there is some deficiency that is occurring, the mother is able to provide it. So usually the problems in most metabolic diseases start when the baby comes out of this mother's womb, and it can present from day 1 to adulthood. So there is a wide variation by which these metabolic diseases can be presented. Functionally, you could divide these metabolic diseases into various things. There could be some metabolic diseases which could really have no harmful effects, and whether to call them as metabolic liver disease. For example, Gilbert syndrome, where you have slight elevations of your bilirubin, but really causing not much harm to anyone. And whether it's to be considered disease or not itself is a big issue. The second possibility is the liver could be morphologically normal, hardly damaged, but there could be a problem because it causes severe effects to other organs. Nothing to the liver, problem in the liver, but damage somewhere else. An example of that is primary hyperoxaluria, some of the amino acidopathies, the Crigler-Najjar syndrome, where the problem is in the liver, but the damage is to the brain. There are others where you may have mild morphological abnormalities of the liver. It's not that the liver is completely normal. There are some small problems, like in a urea cycle defect. When there is decompensation, there could be a little bit amount of fat in the liver, deposition. But this is not going to cause any damage to the liver, but again the damage is to the other organs like the brain. There could be some where the damage is going on to the liver to very minimal extent. It's a slow going damage to the liver. But the major problems are elsewhere, like the GSD1 and the GSD3. And of course the commonest which we see, the galactosemias and the tyrosemias, where the problem is in the liver, the damage is to the liver, very, very vast damage right from the beginning and requiring immediate management and treatment, and some of the topics that this is going to be discussed over a period of time. Because of the concept that most metabolic liver diseases require transplants as an outcome. And in most Western situations where liver transplant is responsible, 30% of the indications of liver transplant may be because of metabolic problems. And another way to classify metabolic liver disease is where the defect is primarily in the liver, just confined to the liver. Obviously, these are the conditions where a liver transplant is most likely to be effective, as compared to those conditions where the defect is in the liver but also elsewhere. And I've given some examples over here. What is the data that is available in India? Unfortunately, like most data, we have very, very limited data, very paucity of data. This is a study that came around 10 years ago from the pediatric centers. Looked at almost 809 children grouped from various medical centers which were involved with a lot of metabolic problems. And at that time, this was I think 1999, 2000, it said that there was 20% of the chronic liver diseases or the liver diseases that were there were metabolic in origin. But there was a very large chunk, 40% of the chunk, which was idiopathic. And to my mind, most of or significant portion of this so-called idiopathic or so-called group where we did not make a diagnosis at that time, 10, 12 years ago, also had a very strong component of metabolic. If you look to the data which we have at KEM Hospital, because through my seniors we have been looking at liver diseases right from 1980s and it's going on. In the 80s, the disease which was the number one disease was the Indian childhood cirrhosis. Over a period of time, this has gone down. And if you see the diseases that we have got, and this is the columns show the average annual incidence per year, we rarely see Indian childhood cirrhosis. We see a large number of Wilson's disease, which is a metabolic problem. We see other metabolic liver diseases, and this is the glycogen storages, the galactosemias, the tyrosinemia, etc. So almost 35 to 40% of the hepatology work in the pediatric practice is related to metabolic liver disease. A significant amount of work which pediatric hepatologists have to see on day to day. In my mind, these are the commonest, and as we go on, we may be able to discuss a few others. Galactosemia and tyrosinemia, and more PFIs is being picked up nowadays in the younger age group. In the older age group, without doubt, at least in our center, and there may be some referral bias, Wilson's disease, followed closely by glycogen storage and the lipid storage. When I say that galactosemia, tyrosinemia, and PFIC are the commonest, they are the commonest that most pediatric hepatologists see. But if I were to talk to people who are doing primary metabolic work, if I would talk to metabolic geneticists, if I would talk to my neonatology colleagues, they would maybe put mitochondrial disorders, respiratory chain disorders as high on the list as galactosemia and tyrosinemia. It is quite likely a large group of these multisystemic metabolic problems which affect the liver don't reach the pediatric hepatologist, but ultimately have problems and maybe even die right in the newborn period or in the neonatology. The neonatologists may be seeing them far more than we, the hepatologists. As a group, metabolic liver disease, as I've said, makes up 30 to 40% of my practice. But individually, they are rare. And therefore, for a pediatrician to try to understand or to look at the clue or king points which make them get a diagnosis is sometimes very difficult. The signs and symptoms are very non-specific. Sepsis and MLDs go hand in hand. And sometimes you may diagnose sepsis without realizing that there is an underlying metabolic liver disease. Classical example is galactosemia. Though there should be a family history, we know that we have a lot of sporadic cases. There is a lot of genetic heterogeneity. The same disorder like tyrosinemia can present in newborn period or in older children or even in the intermediate age group. And of course, what causes the most problems is the fact that we have lack of some diagnostic facilities in making some of them. So if you want to suspect, you would suspect in these situations. If there is a family history of a liver disease, definitely. Liver disease with recurrent episodes, developmental delay, with encephalopathy, massive organomegaly but no jaundice, rickets deformism, hypoglycemia, and if you do a liver biopsy, the liver biopsy shows steatosis. These are some of the factors that should make you suspect that this is the child who has got a metabolic problem. Another thing with metabolic liver disease is that they have multiple presentations, and those are the presentations that we will be seeing over the next day or two. They can present with liver failures, they can present with chronic cholestasis, with organomegalies, or even sometimes with unconjugate jaundice, like cricketer Najar, or occasionally in children even with galactosemia. So to summarize, really, what we are going to see over the next 2 days is that though the metabolic diseases are individually rare, if you put them as a group, they are collectively common. And I think it's important for all pediatricians, physiologists, as well as the adult gastroenterologists who are here to understand and to know how to pick them up. It obviously requires a high index of suspicion. They cannot be commonly differentiated from other causes of liver disease in that particular area. So you need to suspect and then plan towards getting an approach to the management and the diagnosis. We are still short of developing some diagnostic facilities. Things are improving year by year. We are making more and more diagnosis of diseases which we were not doing once or few years back. But we still have a long way to go, especially in some group of disorders like the fatty oxidation, the mitochondrial disorders, the respiratory change disorders. Of course, the question will come as we diagnose more and more what we are going to do in terms of the long-term outcome. And these sort of questions which we have talked about, I think will be discussed in the subsequent sessions today and tomorrow. Thank you.